If you just got a prostate cancer diagnosis and your doctor gave you two options, surgery or radiation, and told you to think it over and come back next week, I want you to watch this before you make that call. I'm Dr. Ajay Bhatnagar. I'm a radiation oncologist, and I've treated over 15,000 men with prostate cancer. And I want to tell you exactly what I would do if I got that diagnosis tomorrow. The specific steps in order with the reason behind each one. Because the way most men make this decision is built on one problem they don't know they have, and it starts in that first appointment. Here's what happens in that room. The doctor hands you a list of options. You're scared. You want to move fast. And the doctor in front of you has been treating prostate cancer for years, so you trust the list. That makes complete sense. But that list only includes what that clinic does. If the doctor performs robotic prostatectomy, that surgery will be on the list. If the clinic runs an external beam radiation program, radiation will be on the list. The list reflects what they offer, and that's all it reflects. This matters more than almost anything I'm going to tell you. The first doctor you sit down with almost always becomes the doctor who treats you. The decision feels like it's about the cancer when it's actually about where you sat down first. So, before I tell you what I do, I want you to understand why the sequence I'm about to walk you through is the one thing that keeps that default from happening. The first thing I do is walk out of that first appointment without committing to anything. I don't mean be rude about it. I mean, I'd say I need some time to see a full comparison before I decide. Any doctor who pushes back on that is telling you something about how they practice. A good doctor will respect it. Low risk and intermediate risk prostate cancer rarely has a deadline. Waiting 2 or 3 weeks to get a second look doesn't change your outcome. The urgency you feel is real. The medical deadline almost never is. The second thing I do is ask for the outcome numbers on every option that fits my case. Not one at a time, side by side, on the same page for my specific Gleason score and stage, cure rate, sexual function, and bladder control. Then downtime as its own question, because that one changes how you plan the next several months of your life. I've seen men choose surgery without knowing that for men over 65, robotic prostatectomy carries more than a 65% rate of permanent impotence and more than a 25% rate of long-term incontinence. Months of recovery on top of that. None of that shows up if you're only comparing options from inside one clinic's program. But there's another number most men with intermediate risk prostate cancer never hear about. If your doctor recommends external beam radiation for intermediate risk disease, the standard protocol requires 6 months of hormone therapy alongside it. That hormone therapy is called ADT, androgen deprivation therapy. In those 6 months, ADT causes hot flashes, impotence, and loss of libido, then fatigue. Those effects go on the comparison sheet, just like surgery does. When you're asking for the side-by-side numbers, ask specifically what ADT is required for each option and for how long. The third thing I do is find a doctor who performs LDR brachytherapy, also called a prostate seed implant, and book a consultation to find out if I qualify. When you got your diagnosis, what did your first doctor tell you to do? Drop it in the comments. I read every one. LDR brachytherapy is a one-time outpatient procedure that takes about 30 minutes. You go home the same day, and most men are back to work the next morning. For low and intermediate risk prostate cancer, the cure rate is above 98%, and 76% of men keep their sexual function after the procedure. The main requirement for qualifying is prostate size. If your prostate is under 60 grams, you qualify. That measurement comes from the ultrasound urologist already has on file. You can call and ask for it. When you get to that consultation, ask for specific things. Ask what your cure rate is with brachytherapy versus your cure rate with the other options your doctor recommended. The number should be specific to your Gleason score and stage, not a broad estimate. Ask what the expected impact on your sexual function is and whether that's based on published literature or on this practice's own outcomes. with their own patients. You want both numbers, and they should be able to give you both. Ask whether the procedure requires general anesthesia or whether local anesthesia is an option. There's a version of the procedure that uses only local anesthesia, the same numbing you'd get for a prostate biopsy. You can drive yourself to the appointment and drive yourself home that same day. That option exists. Most men have never been told it exists because most clinics don't offer it. Knowing whether your doctor offers it tells you how to plan your week and whether you need someone to take time to off work to come with you. Ask whether a rectal spacer can be placed at the same time. I place a gel called Bear Gel between your prostate and your rectum to reduce radiation exposure to the rectal wall. When it's done alongside the seed implant, it's one procedure, one time under anesthesia instead of two separate appointments. If the clinic does both, you want them done together. The fourth thing I do is make my decision after that consultation, not before. If I qualify for brachytherapy, I now have a real comparison. Brachytherapy gives me a 98% cure rate, same day discharge, and a 76% chance of keeping my sexual function. Surgery carries a 65% higher rate of impotence permanently and months of recovery. External beam commonly means 6 months of hormone therapy, at least, and with all the side effects those bring. Those numbers are different enough that the decision becomes clear for a lot of men. And now, if I don't qualify, I now have a real reason to rule it out. A specialist looked at my case and said it wasn't the right fit for me. I wouldn't let the urgency of the moment push me into surgery based on the first recommendation I heard. I've treated thousands of men with prostate cancer. I've also had men come to me after surgery asking why nobody told them about brachytherapy. They came in after the impotence, after the incontinence had set in. Some of them would have qualified. The procedure was available. It just wasn't offered in the room where they made their decision. A lot of men hesitate to go looking for a second opinion. Talking to another doctor feels uncomfortable when you've already sat down with someone and heard their plan. But getting a second opinion is just doing your homework. The decision you're making is permanent. The conversation you have to gather information is not. Surgery is permanent. The sexual function you had before surgery does not come back once it's gone. That's a deadline that stays with you for the rest of your life, and it deserves more than one consultation. I treated a man named Ricky. He was 59 years old, a fitness trainer in Atlanta. His first doctor told him surgery was his only option and that he'd need to stop working out for months. Ricky could not afford that professionally or personally. He found brachytherapy on his own, flew to Arizona, and had the procedure. He was back to his full training schedule the following week. He's cancer-free. The procedure, his first doctor told him, wasn't available, had a 98% cure rate, and cost him nothing in downtime. I treated another man named Tom. He owned a pool cleaning company. Surgery would have kept him out of work for 3 months. He would have gone bankrupt. He came in for a second opinion, had the brachytherapy procedure, and ran his business with no downtime, cured. And I treated a man named Michael. He was 68 and had high risk prostate cancer. His first doctor recommended 2 years of hormone therapy alongside external beam radiation. The projection was 65% cure rate and permanent impotence. He came to me. We did triple therapy, external beam combined with brachytherapy plus 6 months of hormone therapy instead of 2 years. His cure rate went from 65% to 92%. Within a year, he was back to normal life. The pattern in all of 3 of these cases is the same. One more conversation before the deciding was the move that changed the outcome. You didn't cause this diagnosis, and the pressure you feel to move fast is understandable, but the sequence matters. One more consultation with a brachytherapy specialist before you commit to anything is the difference between a decision based on the full picture and a decision based on one doctor's list. If you want to understand why brachytherapy disappeared from most clinics in the first place and what changed in the US payment structure that made it stop being offered, watch this next. It's called After 15,000 Patients, I Changed What I Recommend for Prostate Cancer.